I'd like to say thank you very much to the conference organisers for giving me the honour of delivering this talk on the state of the art of Hallux Valgus minimally invasive surgery. I can't claim to know everything about the state of the art of Hallux Valgus surgery, but I've reviewed the literature, and not just on minimally invasive surgery, but also on open surgery, and also giving you some thoughts about how my practice has evolved. I'm not saying that's the state of the art, but perhaps there's some discussion points around that. There's been a lot that has happened since the last GREPNIP meeting, and since I got involved, which is just after the Myerson paper came out, showing the disastrous results of his series of the first 13 patients of the trial, which he then abandoned because of the failure. This period is what I call the Dark Ages, and during those Dark Ages I was ashamed to show my face to some of my colleagues who thought that this was a really crazy thing to do. But I think we're now going through a renaissance period where there's a massive growth and interest in minimally invasive surgery, helped in large part by the MICA, but also in the development of other techniques that have come alongside this. And we're seeing a real change in the number of people that are doing minimally invasive surgery, and those of us that are doing it can now come out of the closet. So I'm going to look at the latest literature in minimally invasive surgery. And since our last meeting, we now have some papers on this. We have series, we have randomized controlled trials, and we also have some systematic review. So for the first GREPNIP meeting, we're able to talk about some evidence. I'm also going to discuss what's new in open surgery. There are a couple of developments that are happening in that, which I think are quite interesting, and that is the evolution of fixation, and also the concept of rotational correction, which is really gaining traction in the open field. A number of members of GREPNIP have provided me with some assistance in doing this by publishing systematic review last year on the literature. They took each type of technique in isolation and reviewed the evidence for each one of those. The Revedan-Isham technique is a method that's used very successfully by a number of experts, including members of our society who have published it as recently as 2016 with very successful results. But overall, in systematic review and in randomized controlled trial, the shortcomings of this osteotomy are revealed. Its ability to correct is less than the other types of osteotomy, and it's generally out of favour, though there are still experts practicing this very successfully. The same is true for the Bosch and Siri osteotomies. There are numerous trials comparing the Bosch and Siri to Scarf and to Chevron, showing that in the hands of experts this can be a very good operation. However, concerns are about the degree of fixation of the metatarsal head and the need to stabilise the joint for 6 weeks or more. And there are definitely papers that show that there's an increased risk of malunion, non-union, transfer metatarsalgia and recurrence. The systematic reviews show that this can be up to 20% or even more. Myerson's paper showed an incidence of malunion and non-union of 69%. And this has been repeated in many other studies. These are the results of Myerson's trial, which had to abandon after the first 13 cases. The MICA osteotomy, which is the minimally invasive chevron Aiken osteotomy, is something that's much more recognisable as an open operation. It obeys the principles laid down by Baruch and others of Hallux Valgus reconstruction, and also observes the AO principles of anatomical reduction, rigid fixation, early rehabilitation. It's, as well as this, an extra-articular osteotomy, and it's been shown to be equivalent to an open chevron osteotomy by a number of authors, who are all members of society, and at least two of whom are in this room as we speak. And they've shown that there's equal correction to an open chevron. Moreover, it can be done faster than an open chevron. Two trials have compared it to the open chevron and showed that it's a much quicker operation. And of course, there are health benefits to this. It's not just about trying to get out of surgery quicker. The less time it operates in, the less infection. We've shown that it's not as locally destructive. So there are improvements in preservation of the blood supply compared to open surgery. We worry about nerve injury, but there are many studies that show that nerve injury is uncommon in clinical analysis, but also in a number of anatomical studies. So is the MICA just the same as an open arm operation, but just with less soft tissue dissection? Well, the evidence really shows that it probably is. A number of papers have compared minimally invasive chevron to open chevron with equal correctability. And I don't think that that is argued about in any paper that I've come across. I think we can take that to be a fact. And of course, the advantages of this are that doing it minimally invasively is that there is better early pain relief and patient satisfaction. However, it does appear that this early pain relief is not maintained in the long term, and a number of studies have shown that in the first 2 to 6 weeks, even up to 3 months, that the pain relief and patient satisfaction is better with minimally invasive than open. However, by the time we get to 12 months and 24 months, they're of equivalent benefits. And again, I don't think there's any paper that shows a difference in the longer term in terms of pain relief. For sure, this is associated with less soft tissue complications. Again, I think this can be taken as fact. There are so many studies now that have come out comparing the minimally invasive chevron to an open chevron or open scarf. Frick's paper showed better range of motion. This is the only study that's really looked to analyse one of the, I think, great advantages of minimally invasive surgery, and that is preservation of range of motion. Unfortunately, this is a really difficult parameter to measure, and as a consequence, it's easy to ignore this in our studies and focus on X-ray correction. But I think this is where the real advantages of minimally invasive surgery lie. My own series of 108 MICAs versus 127 open chevrons showed lower infection rate and lower risk of stiffness. But all is not perfect, and there are issues with this that mean that it isn't quite the equivalent of an open chevron in certain respects. Frick's paper in Foot and Ankle International this year is a really great study and a really honest appraisal of this. This group looked at 50 open scarf osteotomies against 48 MICA osteotomies. Now, this wasn't his learning curve. He was already a very experienced minimally invasive foot surgeon with 2 years of minimally invasive surgery, and I think something like 200 osteotomies under his belt by the time he did this. But even by that stage, 14% of the MICAs that he set out to do were converted to open surgery intraoperatively because of difficulties in completing that surgery. All the MICAs in his study were shortened by 3 millimeters. The complication rate was 27% for MICA and 8% for scarf. Really, it probably ought to be more than 27%, because if you look at intention to treat, this should also include the 14% where the MICA was abandoned in favour of converting to an open operation. Now, we all know about screw removal and the issues that that raises. It invariably means a second operation, but this is low risk, low complication, and doesn't seem to have any functional issue. There are obviously economic problems with it, but it doesn't appear to have any clinical problems. So even if you take out screw removal, the risk of complications is still substantially greater in the minimally invasive versus the chevron group. We know that screws are a problem, even with the changes in the technique that have been implemented over the last 4 or 5 years, the change in design of the screws. This remains an issue. All 3 of these papers have been published since those modifications have occurred, and show a screw removal rate of between 11 to 20% and up to 25%. Another issue which comes to light from many of these papers is about the learning curve. This is another really great paper from Australia by a surgeon who is a prolific minimally invasive surgeon. He's not anti-minimally invasive surgery, he does a lot and is very successful at this. But when he reviewed his first 60 patients and compared that to his second 60 patients, he saw a difference in the complication rate of 40% versus 26%. It's interesting that even despite this, the clinical functional outcomes were roughly the same. So it goes to show that the soft tissue advantages of minimally invasive surgery are really quite substantial and do outweigh some of the mechanical problems maybe that we're experiencing. In breaking down each of the complications that he had in those first 60 patients, screw removal obviously features heavily. But this paper was done after we'd modified the technique. And despite that, there were other complications. So fracture is another problem that comes. So even if the screws are being placed, we do have an issue with trying to hold that reduction. This is my own series of my first 108 mica chevrons compared to contemporaneous cohorts of 130 open chevrons, which I did at a different hospital. And this was patients in 2009 to 2011, and included my learning curve. I looked at radiographic outcomes and also looked at clinical outcomes as well as complications. Even in this first 108 patients, there was equivalent radiographic outcomes. So we've got an operation that is really quite good at getting a correction. There were associated clinical functional benefits from that. This is probably not clinically significant, but it was certainly statistically significant. Loss of fixation and screw removal were the biggest problem. And for this group of patients, I used the same screw technique for my open as well as my minimally invasive patients. And there was still the same issue of the screws being needing to be removed. This isn't a failing of minimally invasive surgery. This is a failing of using a screw that was designed to be put in perpendicular to the bone, compressing the fragment onto the body, and was never really designed to be used retrograde in an oblique fashion such as this. And so I think this is really an issue of screws rather than minimally invasive surgery. But loss of fixation was a greater issue in my minimally invasive group. The soft tissue advantages were definitely better for minimally invasive surgery. So, why do we do MIS? It's not about correction, because all we've really been able to show is that it's equivalent to open correction. We do minimally invasive surgery to avoid complications of the soft tissues, to allow early rehabilitation. My patients start active movement in the first 2 weeks. I teach them how to do passive range of motion for the next 2 weeks, which I get them to push quite hard. And then from 4 weeks onwards, they start to do some weight-bearing range of motion exercises. This requires and mandates rigid fixation that is stable. And if we can do that, we can really take advantage of the fact that we've had less soft tissue dissection. But fixation is critical for this. This is a patient in the recovery room straight after waking up. Obviously, there's an anaesthetic block in there, which is why they're quite comfortable. But this lady came from 200 miles away, and so she stayed in overnight. And even after the anaesthetic block has worn off, this pain relief from having a rigid fixation is still maintained. And that's something that every paper that has ever looked on the early outcomes of minimally invasive surgery has shown. If you can get rigid fixation in 2 weeks, you can have a very normal looking foot. There's no need to brace these patients. And you can look forward to getting really rapid healing. This lady is 5 weeks out from surgery on her right foot. These are the outcomes at 7 weeks. And we know that if you can get a good early range of motion, you can maintain this forever. This lady came back to see me for 8 years later. So that critical early first 2 or 3 months is really vital in determining what your long-term range of motion is. Now, I did a little survey of surgeons doing minimally invasive surgery, and I broke down the operation into each of its constituent parts, every small step in minimally invasive surgery. And I asked those surgeons to grade each of these steps. on a scale of 1 to 5. 1 being something that you can tell your intern to go without them ever having seen it, ever having done one, and you're not even going to be there to help them. Grade 5 is something that even an expert finds difficult and won't always get right. There's only really one step that is above a 3, and that is insertion of the wires. Now this is the opinion of people who've done quite a bit of minimally invasive surgery and still find that that wire placement is an issue. For us to be able to pull Mika into the central group of surgeons who are 2 standard deviations, which is all of us in this room, as much as we like to think of ourselves being at the top end, we're all about the same. And for this we need to have consistency of wire placement and also fixation. Reviewing my fractures has led to a change in the way that I do my osteotomy. And this is just to show you how my practice has evolved. They all broke in exactly the same way. Firstly, this lateral screw was put on the wrong side of the cortex, and as a consequence was allowed to windscreen backwards and forwards. And it really needs to have a rigid hold. You need to be able to get it from cortex to cortex and into the head. It isn't just acting as a buttress screw, it is also holding the metatarsal head. The second issue was that the medial screw was blowing out through the side of the medial cortex. In every single one of my patients that had this. These are 2 different patients with almost identical problems. So it was clearly a problem of process and the way that I do this, because it was exactly the same for all the patients that I've had. And I started off my practice, as we all did, doing a long-tail chevron osteotomy. This is the standard that we had back in 2009, 2010. What it means is that the cortex that you're aiming for to put your screws into is really rather narrow. And I think this is one of the issues that we have with a screw blowing out on the medial side, because the cortex is thin, and especially if you then take off the medial eminence on the corner of the shaft, that further destabilizes this. So it's meant that I've moved to doing a shorter and shorter tail chevron, and now to doing a straight cut, which is much more like a Bosch osteotomy. So this is a patient from 2009 on the left, which is really like a true chevron with a long tail. And then a patient from 2016, which is virtually like a Bosch, which is straight osteotomy. But I've also changed my fixation. This is what I was doing as a chevron in 2008, a single dorsal screw. But this was an issue with fixation. So then we moved to adding on a medial screw, which is this buttress screw, which certainly helped. Then we found out that this dorsal screw was the one that was most likely to back out and create a screw impingement, require screw removal. So then we moved to doing 2 medial screws, trying to catch that lateral cortex. But screws are still backing out, so the screw design changed to having an oblique head. But still, you know, this is like a delicate Japanese version of things, holding it with chopsticks. You're skewering this from a distance. This is not the way these screws were designed to be. Compression screws are designed to come the other direction, and they're not designed to be put in obliquely. And then this lady came along. I put in the first 2 oblique screws, and they were perfect. I tested the osteotomy, and it was really loose. There was no hold whatsoever, because she was really osteoporotic. And so what I did then is to put in an intramedullary screw from distal to medial. And despite having very little bone contact, she got really a rigid fixation. And this is a more British beef version of intramedullary skewering and then grabbing it from the sides. Eventually I dropped doing the second oblique screw and just relying on a distal compression screw and my buttress screw. But then in the last couple of years, we started to get intramedullary plate devices, and this is really starting to get to be something that's much more rigid. It also means that you're not relying on that medial cortex for hold, and you can shave off as much of that as you wish. So this is the lady that started all this for me, who was really grossly osteoporotic. And I put that third screw in, and then I got a rigid fixation. And what it meant was that I could get her to rehab in exactly the same way that I rehabbed all my other patients. And this is her at 6 weeks, post-op. So she's also been doing active and passive range of motion from the beginning, and weight-bearing exercises from week 6, with very little bone-to-bone contact, but you have the confidence to have a rigid fixation. Here's another patient at 6 weeks. Again, despite very little bone-to-bone contact, starting immediate range of motion rehabilitation exercises enables you to get really good functional outcomes. So going back to the systematic review, they also cover this intramedullary fixation. This is definitely a growing trend, not just in open surgery, but in minimally invasive surgery too. They found 3 studies using this for minimally invasive surgery. Since the publication date of this, there are another 2 or 3. And they've shown that in these early papers, that the hold is much better, and the incidence of malunion and non-union is really very low. These papers were done in open patients, but in a mini-open version. They weren't done completely percutaneously. There's a paper that was accepted for presentation here, but unfortunately the author's not coming, who has done 120 percutaneously with a 2mm Shannon burr, and then a percutaneous entry of the plate. He's not alone. This paper from Diaz Fernandez showed their plate done percutaneously with a 2mm Shannon burr. And finally we come on to rotational correction. This is something that Emilio and Pablo Val and Christian Ortiz have been promoting, and I really think that there's something in this. But actually, if we're able to do a straight chevron, instead of a chevron cut, doing a straight cut, and we're able to get a rigid fix, then we can start to look at rotation as well. We use the tail chevron because of stability. Now, if we're able to do a straight cut and still achieve stability, we can start to do rotational corrections, and this has certainly made a difference in my practice. So how does this change my practice? I've changed osteotomy, I focus more on rotation, I've changed my screw fixation, and I'm changing to plate fixation. Looking at the literature, I can confidently say that minimally invasive surgery has delivered less painful surgery, less soft tissue complications, better range of motion, better satisfaction, excellent correction. But we still need to improve on work on improving the learning curve, reproducibility, and develop maybe some MIS-specific implants. And fixation is important, I'm afraid. Thank you.
Thanks a lot, Anthony, for this huge work. So, do you have very quickly question, Anthony?
Question. Sometimes you're not able to overcome all the deformities, and you just need to go for a adductor release and aching osteotomy. What is the pathway of you? Usually you're going first for the aching osteotomy or straight for the adductor release? Because I noticed sometimes that once I'm going for adductor osteotomy and I didn't get enough correction, if I do the aching after the adductor osteotomy, I can end up with varus. So I just want to see what you think.
The answer to this question is directly related to my experience. When I started, I was doing a percutaneous lateral release in every patient. I must have done nearly 1,000 or maybe more than 1,000. I can't recall a single complication from a percutaneous lateral release. So I used to do that routinely. The aching osteotomy I used to do really frequently too, maybe 80-90%. But as I've got better at pushing the chevron osteotomy, I now do it very rarely, and I avoid doing it at all in severe Hallux Valgus because it increases the risk of Hallux Valgus. So, you know, I would approach that by more or less always doing a lateral release and doing an 18 osteotomy carefully with caution, but not in every patient. I try and avoid doing it as much as I can.
Okay.
Rotation will really help with that, by the way.
Thanks a lot, Anthony. So finally, the take-home message is probably the weakness of MIS is the learning curve. So that's why it's very important to discuss about the technique and to learn to do these techniques. And the other tricks we can give is please be careful with the learning curve. Don't start with big translation, start with small translation, and then step by step increase your practice.